تمام. Bismillah ar-Rahman ar-Rahim. Welcome again, all of the residents in Sudan and everywhere and elsewhere. This is Dr. Amani Khalifa, and I'm obstetrician and gynecologist in Women Wellness and Research Center, Hamad Medical Corporation. And currently, I'm a president of Sudanese Doctors Association in Qatar. This is the humble effort for our residents as a preparation for the OSCE exam of second part of Sudan Board Certification Specialization Board. This is our 8th session, and we tackle different topics during the previous period. And now we are in this session, we will talk about obstetric and gynecological emergency. Actually, I don't think the time will allow us to cover both, but I will concentrate on obstetric emergencies. And my objective after this session, that all or most of the candidates who are attending will be able to score the highest mark in the stations of obstetrics and emergencies. So obstetric emergency السهل الممتنع, the easiest and could be the most difficult as well, because you have to score a very good mark in this station, and it is not acceptable for any candidates or anyone who is board certified who is not or she is not able to tackle any obstetric emergency at any account. So the examiners will be very tough during that station. The pass mark will be high for such a station. It is the bread and butter of the obstetrician. You do it every day, but the way that you present yourself doing it in the exam is different from the way that you are doing it in the real life. And maybe that is where the difficulties comes from. Right. What are the general concepts of the obstetric emergency station? They are the most vital stations, the stations that candidates can achieve the maximum score. It tests the skills as well as applied knowledge. Make use of mnemonics. And how are you systematic? And your answer is stepwise manner. You have to be very organized. Can I ask everyone to mute? Mute your mics, please. Okay. It is not only that which drugs you will use during the obstetric emergencies, but the doses are very important. The antidotes, the side effects, and everything in relation to drugs that is used during emergency situation. You need to be very aware of it, and you know it by heart. Prepare your strategy to answer before start. And this is the golden minute rule. The golden minute rule is if everyone who attends this course, a preparatory course, is just take the message or the take-home message that is very valuable is the golden minute rule. The golden minute rule is the minutes that before you start answering, before you start embarking on answering any question in the OSCE station, you have to have this 1 minute. Even if you know everything about the station, don't be in a rush to start answering. Before waiting, organize yourself, put a strategy in front of your eyes, and then start answering. Otherwise, you will mess up. Okay? It's time management is very important during this station because some of the stations are long stations, some are short but detailed stations. So you have to be well organized. You have to make use of the strategy. So you will not start haphazardly and jumping here and there. Because in the emergency, it is not acceptable. You need to be the team leader and you need to know each step and when at the timing of each step that should be done. It is very vital how to answer. All emergency or skill stations has either one or more domain. What are the domains? The domain, that means what is the objective of the station? Is the station testing your ability to perform the skill? Or is the station is your ability to communicate while doing the skill? Or is the station is testing your knowledge about the emergency situation? Or is the station is about how you will teach the station? And this is the new format of obstetric emergency stations. So the previously, the emergency obstetrics or gynecological emergency stations, skill stations are only testing your skills. Only. يعني perform breech delivery, perform management of patient has PPH. How are you going to manage? But things have been changed lately to different domains. It could be just communication skills. Communication skills that you explain to the patient what will happen, patient and family during the situation, or communication with your team about the station or the emergencies that happen. Or you teach a junior one. For example, you are R5 or R6, and you asked to teach your R1 resident how to manage shoulder dystocia. So when it is teaching, it is different. You tackle it differently. When it is the skill performance, you tackle it in a different way. And when it is communication, you tackle it differently. And we will talk about the communication, all the communication skills in a separate session. You need to start by addressing the situation. أي emergency, obstetric emergency, you need to start by addressing the situation. For example, this is a life-threatening condition. This is a top emergency condition. This is a situation that carries high maternal morbidity and mortality. This is a race against time station, okay, أو situation. So you have to address the situation. وده واحدة من الحاجات ال very important في strategy, strategic answering. يعني you know, it will be very clear, this is shoulder dystocia. لكن I want to hear from you that this situation is a top emergency and it's a time race, or I'm racing against time in such situation. عشان كده time, seconds matter in the management. So addressing the situation is the start of your answer. ودائما بيكون عندها مارك، يعني عندها درجة، بيكون عندها درجتين. Okay, just to say shoulder dystocia is a top obstetric emergency. Postpartum hemorrhage is كده, is an obstetric emergency. Or even if it is not clearly stated in the scenario, يعني you have been called for delivery into the labor room number 5, where a midwife was delivering a big baby and the head delivered, when there is difficulty in the delivery of the rest of the body. So you need to say that this is assessment, this is a shoulder dystocia, then I will start managing like that. So addressing the situation is the first step. Second step, team of management. All, it's a rule. Emergency, you will not tackle it alone. You need to call for help. Call for help is not enough. And if you say call for help in the station, and you didn't say whom you need to call, or what is the team that you need to be involved with you, the helpers for you, how many helpers you need, what are these helpers, or what is the level of these helpers, okay? It's not enough. It's not enough just to say call for help or ask for help. Emergency team, multidisciplinary, anesthetist, midwife, extra personnel, timekeeping personnel, whatever. Okay? Place of management and positioning. Place of management. Are you managing this patient in the labor ward? You are taking the patient to the OT. Where is the management? Where is the location of the management? Okay, and this will give you an idea of need for the transfer of the patient, whether this patient needs to be transferred immediately or stabilization and transfer. Positioning is very important. Not always left lateral position is a standard. كده, especially for example in maternal cardiac arrest or maternal collapse. You don't put the patient on her left lateral position while doing the CPR because CPR is mandatory. The positioning of the patient is very important. Cord prolapse is not left lateral position, it's Trendelenburg position. And always, almost always, the position and the place of management has a mark in the checklist. عنده وزنه في checklist. Okay. Mnemonics. Which mnemonics you will be using while answering the obstetric emergencies? Are you following? You will follow A, B, C, D, E, F, G, H, I, J for instrumental delivery, or you are following the helper mnemonics for shoulder dystocia, or you are following careful for bridge delivery. Which mnemonic you will use? And you don't need to say the mnemonics, لكن the mnemonics helps you to be systematic and not to forget. الفكرة في النيمونكس أصلها إنه التذكير بسرعة، يعني you will not miss. You will follow a sequence and you will not miss any step. Remember the ergonomics. Which are the ergonomics? Light, setting, patient at the end of the table, instruments to be ready. These are the ergonomics. يبقى إذا نظمنا في الجولدن minute you think about it. تقول first of all I will address the situation, a team, الposition, الergonomics اللي هي light, التable, instruments, towels, whatever, and which mnemonic I will follow. Okay, خلاص كده you just put your strategy for the answer. Act in confidence, and that is very important. In confidence, not in a rush. يعني in confidence is more important. Remember, you are in the exam. You are not in the real situation. يعني انت ما مستعجل انك انت تسيب ولا عندك براديكارديا ولا اي حاجه. البيبي you will miss that. You will lose a baby ولا you will miss anything. Act in confidence. لكن في نفس الوقت don't be very slow and very relaxed. I know in the exam some of the candidates they will be like we call for help until you feel that they are running. So you don't need this. You need to be clear, confident, and systematic. Systematic stepwise performance is very important. Abilities to communicate with patient and staff and teamwork. Always remember, briefing, huddle, and debriefing. Briefing is, what is briefing? Briefing is the communication with your team before the procedure or before the emergency, the situation that happened, yani before what you will do. This is briefing. Huddle is during the procedure and debriefing after the procedure. So you always remember that. I will do briefing, huddles, and debriefing. And debriefing and documentation are the most important Ds at the end of any obstetric emergency. Debriefing and documentation. Okay. I always say to the people that even if the time finished and you are asked to leave the room in the exam, at the door, tell them the 2 Ds, debriefing and documentation. And then you will get the full mark. This is the last mark in the checklist, debriefing and documentation. I'll start for in the obstetric emergencies of most of them. I think I didn't put only the eclampsia because eclampsia, it needs to be like separate one. I think so. So we'll start by the forceps delivery or instrumental delivery. Yalla, I need someone to do it. The situation is patient primary gravida. Yes.
أنا كنت أبدأ لك
primary fully dilated for 3 hours. You have been asked to conduct the delivery for such a patient. CTG category 1, she's fully dilated for 3 hours and she is on epidural.
follow A B C اللي هي في ال A عندي أول حاجة address the patient asking for help analgesia و abdominal examination اللي هو ال head should be engaged more than 50 per abdomen. B بعمل bladder empty. C in the cervical dilatation and rupture membrane ما يكون في cord prolapse أو avoid يعني إنه يكون أتأكد إنه ما في cord. في الدي اللي هو بدخل بعمل determine الستيشن والبوزيشن should be below ischial spine at أو below ischial spine. في الإي اللي هو الإيكومنت should be ready إنه يكون عندي forceps والليبر set والنيوناتال resuscitation set. بعد ذاك في الإف الفورسبس ذاته اللي هو المفترض أعمل شوف الفورسبس باك تو باك and بعملهم مع بعض أشوفهم هم هو تيست الفورسبس قبل to be used. an application of forceps اللي هو بشيل right pencil grip اللي هو الرايت فورسبس بالرايت هاند ببنسل جريب بخش بيه في الرايت سايد اوف الرايت واعمل بالليفت بدخل بعد ذاك الرايت فورسبس تو بروتكت انه ماشي الماتيرنال تشو معاي في لما أدخل الفورسبس.
Which one first? Which one you will apply first? Left ولا right? Which
left.
one you
ببدأ
will
بالليفت.
apply first? Left or right?
left.
Left one, yes.
الرايت بشيل برضو بالرايت هاند، بشيل الرايت فورسبس، وبالليفتي هاند بروتكت الماتيرنال تشو من انه اشيلها مع الفورسبس. قبل ما اعمل لوك للفورسبس اللي هو بعمل اكزامينيشن عشان اشوف الفورسبس ده اول حاجه ما في ماتيرنال تشو، والهيد يكون قاعد لنا في الميد لاين، والفينستريشن يكون 1 فينجر اللي هو ادميت 1 فينجر. بعد ذاك بعمل لوك. افتر ذات اللي هو بعمل بولينج. البولينج بيكون لنا الافضل مع الكونتراكشن. بعمل 3 بول. مفترض اشوف الجو. مجرد ما الجو طلع بعد ذاك بعمل ديتاشمنت، اللي هي بعد ذاك ببدا اطلع الريموف بالرايت. انا ركبت اول الليفت، لما نجي اعمل ريموف بعمل ريموف للرايت اول فيرستلي، بعد ذاك هتن الليفت. افتر ذات اللي هو بعد ذاك بواصل الدليفري عادي، ومجرد ما البيبي طلع أديه النيونيتس. بديه ناس البيدياتريك، بشيل كورد سامبل، وبطلع البلاسنتا اكتيف مانجمنت، بعمل اكسبلوريشن لكل الجينيتال تراكت من السيرفكس لحد البرينيوم. إذا في تير بعمل له سوتشر. افتر ذات بعمل ديكومنتيشن اند بريفينج.
Okay, good. طيب. Anyone? Any other opinions? هل she missed anything?
Active management of third stage of labor.
هو في الكور في الهيربيدر، بس ما قلت انه عايزين اوبستريشن، عايزين ميد وايف، عايزين يعني مفترض احدد التيم اللي انا عايزاه اللي هو بيدياتريشن وكده.
Yes.
والآي for incision للإبيزيوتومي.
She missed the episiotomy, yes. What else?
في الدليفري of the baby based follow budget maneuver في الدليفري.
Also the place of delivery, was it to be conducted in the delivery room or in the theater?
If we put it
according to according to station of the bed.
فولو اب برضه الفولو اب المفروض تكون بالفوليكاسيتر at least 24 hours.
Follicacitor 24 hours if there is a vaginal pack. If there is need for vaginal pack and multiple vaginal tear, then you need to keep a catheter for 24 hours. But for routinely, you don't need to. طيب. You did it good. You missed some things, but the way that you were describing is just following the ABD, لكن you are not following the strategy as you are answering the exam. يعني first of all, I need this patient, she needs to be delivered because he is prolonged labor. She is for assisted vaginal delivery. Okay. Prerequisites of forceps delivery is that it has to be either occipito-anterior, direct occipito-anterior, or direct occipito-posterior. So you did not mention that you will assess before doing the forceps. So assessment is very important. Assessment abdominally and assessment vaginally. Assessment abdominally to give you an idea about the size of the baby, because you have to think of dystocia, especially shoulder dystocia, and that is the thing that you miss during the D. And assess vaginally for the position that is favorable for forceps delivery. Position that either direct occipital anterior or posterior, or if it is not direct, less than 45 degrees from the center. Okay? Station and station, because if it is less than 0 station, you will not be doing a forceps delivery in the labor room. Okay? So assessment, first you clearly said that this situation is for need for instrumental delivery. You did the assessment, briefing of the staff and briefing of the patient. So you address to the patient as everything is fulfilling the criteria to perform a forceps delivery. You go ahead and perform it, and then you can say, then I will follow the mnemonics, the A, B, C, D, E, F, G, H, I, J mnemonics. Or you don't need to say it. You will just say, and you will not say A stands for كده, B stands for كده. You say it in the exam. It is not مش acceptable, لكن it is not impressive. إنك أنت تقعد تقول ال A stands for كده ولا B ولا I will follow. You just, because you are خلاص, you are a specialist. So you're supposed to know this by heart, and you don't need to say it in the exam. So you will say, I am, for example, يعني, without saying it in your heart. And then you say, I will ask for help. Help, immediately, once you mention help, you have to remember immediately who you want to help. I'll inform the senior obstetrician that I will perform a forceps delivery. I need pediatrician to be informed. For example, theater to be ready, or at least notified that I am conducting a forceps delivery, because if it is felt, you will go for cesarean section. So OT should be informed, okay, or at least kept standby. I need in charge or midwife with me, and a neonatologist for the baby's resuscitation, okay? Then ergonomics. Patient position is lysotomy position, preferably at the edge of the bed. Patient has to be at the edge of the bed. Okay? Check the analgesia. If she is on epidural, that will be very good. As the scenario, the patient is on epidural. If not on epidural, the options are either pudendal block, bilateral pudendal block, okay, or local infiltration, if the patient can tolerate. Like, ideally, forceps delivery should be done either under epidural, or under anesthesia, or under bilateral pudendal block. Okay. Now you did all this one. The bladder should be emptied. Cervix should be fully dilated. I'll check for the cervix that is fully dilated or not. If it is confirmed fully dilated, then I will check for the position. The position has to be either direct OA or direct OB, or at least the rotation, the deviation from the midline, not more than 45 degrees. And the contractions has to be enough, because the pull will be with the contractions. Okay, patient will explain to the patient the full procedure, and then I will check my equipments. Equipments including the light, the equipments for the forceps itself, different size of the forceps or optimum size of the forceps, instruments or equipments for neonatal resuscitation, and for exploration, cervical exploration or genital exploration after the procedure. Okay, I will check the forceps as you mentioned. Forceps, good size, reasonable for the patient, and type of the forceps. Preferably, or the most commonly used, the most widely used is navel bound. So navel bound forceps should be there. It has to be matched to each other. So check and make sure that they lock. And then deassemble and assemble again, and see and therefore start the application. You apply the forceps starting by the left and followed by the right one. Lock it. Make sure that it looks nicely. After locking, وانت قلت قبل اللوكينج. After locking, you check for position for safety. Position for safety. P stands for posterior fontanelle should be not more than 1 centimeter above the shank. Sagittal suture should be equidistant in the midline, and the fenestration should not admit more than 1 finger. Okay? And the position for safety is important because it's the alignment and to exclude any abnormality in the position of the head. Lateral flexion or extension. Then you pull with the contractions. Gentle pull with the contractions. If there is a good descent, you assess and you can do now the incision, which is the episiotomy. Okay? When there is crowning. When the jaw appears, then you elevate in a Bajos maneuver. You elevate the forceps upwards until the delivery of the jaw. Then you remove the forceps by removing the right. The latest one applied will be the first one to be removed. So the right blade will be removed before the left blade. Complete the delivery of the baby. If the baby cried immediately, wait for the cord clamping, delayed cord clamping. Then you clamp the cord. If not, you cut the cord and give to the pediatrician for resuscitation. Delayed cord clamping, if done, then you deliver the placenta, you collect blood sample for the pH or for the blood grouping. And then you complete third stage. Okay. Third stage management, then documentation and debriefing. Debriefing of the patient. We did forceps delivery because you exhaust your time for the spontaneous delivery. We need to deliver you because we gave you the maximum time. This is the forceps mark, which is can disappear. Okay. And this is how the Paget's maneuver. Paget's maneuver is you pull outward and downward. Vacuum. There is no big difference, yeah, from the forceps and vacuum. It is the same. A, B, C, E, D, E, equipment ready until E. So from E, equipment ready, including the vacuum, you make sure the vacuum is working. And you need to put the patient at the edge of the table. Always remember the E is edge of the table as well. F, in the forceps, it is forceps application. In the vacuum, it is flexion point. And the flexion point is, you check, what is the flexion point?
Flexion point 3 centimeters anterior to the posterior fontanelle and 6 centimeter posterior to the anterior fontanelle. And the sagittal suture at the center, and we have to make sure that no maternal tissue.
طيب. Is it practical, قصة 3 centimeter or 6 centimeter, is it practical for the flexion point? What is the most practical? How you know that you are in the, this is the flexion point?
إنه كان divided ل
أنا عارفة إنه الناس كلها حافظينها كده 3 سنتيمتر و 6 سنتيمتر، لكن لحد حسي ما في زول اثناء الدليفري بياخد سنتيمتر وبيمجر 3 سنتيمتر ولا 6 سنتيمتر. So clinically what you do عادة you check the posterior fontanelle and the edge of the vacuum cup should be at the posterior fontanelle. The edge لأنه البوينت اللي انت بتتكلم عنها هي center of the cup، دي الفليكشن point. The center of the cup has to be at the center at the flexion point. كويس؟ the center of the cup has to be at the flexion point. The edge of the cup has to be at the posterior fontanelle. تمام؟ وليه اسمها flexion point؟ Why it is called the flexion point؟ ليه يعني البوينت دي بالذات؟
Because when we apply this cup, we must deliver the head at the flexion, at the flexed position.
مش عشان احنا عايزين يبقى فليكشن، لانه هي دي البوينت اللي انت if you apply any
reduce the failure rate.
pull. لا، لانه if you apply any pull من البوينت دي بالذات الهيد بيبقى فليكس. لكن لو خديت الكب دي في اي حته ثانيه الفليكشن ما بيبقى 100% فليكشن. It is the point that if you apply a pull at the head it cause maximum flexion. عشان كده اسمها الفليكشن point. The point that cause flexion of the head. Okay? فهي الفليكشن point هي البوينت that cause complete flexion of the head. And how I will know it? The edge of the cup has to be at the posterior fontanelle. Then you apply the gentle traction. The difference is it is better that the traction will be with the contractions. Okay, especially in the vacuum. It needs good maternal effort. Then what is different in the vacuum is H, which stands for hold the contraction or hold the procedure. Hold the traction, sorry, and hold the procedure. Hold, that means to stop the traction. When you will stop the traction? In between contractions. مش كده؟ If in between contraction you stop the traction. Or if you apply the traction and there is no descent. And if you continue doing this traction and no descent 3 times or 3 pulls without descent, then you hold the procedure. You stop the procedure. Okay? So hold the traction in between contraction. Hold if there is pop off or hold if there is no descent. If you apply the traction 3 times pop off or 3 times no descent, then you should stop the procedure. If you apply the traction and there is descent, okay, you can, what is in the guideline, you can increase the traction up to 6 times if there is good descent. If 20 minutes from the starting the procedure or 30 minutes from the decision of doing the procedure, the vacuum, and the baby is not delivered, you have to hold the procedure or stop the procedure. So if there is good descent and at the crowning, you check for the episiotomy, need for episiotomy or not, because with a vacuum, you might not need an episiotomy. Okay, once the jaw appears, remove the vacuum and complete the delivery of the baby, complete the delivery of the placenta, do the active management of the third stage of labor, suture all the any tears or the episiotomy, debrief and documentation. Debrief the mother and the husband and the family, and debrief the team. Okay. Shoulder dystocia. If the question here is, as I gave you the example earlier, it is not how you will do it, how you teach shoulder dystocia. You are the senior registrar, the senior resident, and there is a new joining R1 resident with one intern, and you are assigned or you have been asked by your consultant to teach them about shoulder dystocia. How are you going to do it? أنا أعمل example بتاع teaching station. How are you going to do it?
Can I start?
Yes. أول حاجة, who are you?
وفاء.
طيب يلا يا وفاء.
With him, I will say to him, we are so happy to join us. Lastly, I know that you are interested on how to doing shoulder dystocia. So today I will tell you the story, and I hope that you enjoy. تمام. Firstly, shoulder dystocia is an top emergency. So when we called already dystocia, put in your mind that is we have a catastrophic emergency situation. Okay, so we will start by address the situation. Then firstly you will we will start by to check this is a true shoulder dystocia. Okay, by examination, there is a certain sign tell us this a true shoulder dystocia. Firstly, sign, which means that the head
Yes.
is go on and out. Also, we can diagnose it by gentle traction, apply gentle traction, and the head will be tightly applied للفالفا. Okay. When we diagnose shoulder dystocia, firstly I will debrief أو I will brief them address المطر situation. We will tell her that this is the pony, the shoulder bone of your baby is tightly applied to your pony pelvis. We will deliver you, and we are trained in doing that. Just we are want you to help us. So don't apply any pushing. Be relaxed, and we are our family, our team will help you. Be quiet and trust in us. Okay, this is how we address the patient, the situation. Okay, then we need a team, so we should call for help. This team already we should have an obstetrician, anesthetist. Therein we will need two assistant midwife, senior house officer, and a neonatologist. Okay, that we can need a neonatal resuscitation. Okay, and we need someone who keeps time. So to tell us is because each step we needed to do should be done in certain period, which is not because each second in our this station is different. Okay, are you happy? Am I clear? Can we move to the next step? Okay. طيب, the first maneuver we will do it. We will do the McRobert maneuver. McRobert maneuver means that we apply hyperflexion on the hip joint and flexion on knee joint and adduction. This maneuver do what? Increase the anterior-posterior diameter and promote flattening of the sacrum. So this will increase a diameter, and it have a very high success rate. This will have success rate about 90%. This step should not take more than 30 seconds. The one who keeps the time should tell us time of move to the next step. The next step is suprapubic pressure. Okay, we do it as same as the CPR manner in rocking or sustained pressure. We pressure on the anterior aspect, on the posterior aspect of the anterior shoulder. So as we the shoulder toward the maternal toward the long diameter. Okay, if this maneuver succeed, okay. Not succeed, we will go to the other maneuver. Am I clear? Do you need any repetition or anything not clear for you? Okay, we will move to the next maneuver. The next maneuver اللي هو delivery of the posterior shoulder. On delivery of the posterior shoulder, firstly, we can make this consultant, or we can proceed. Okay, we can proceed by اللي هو episiotomy if we need. تمام. We enter our two finger of my right abdomen on the vagina on 6 o'clock. Okay, then I will move to the posterior arm and press في popliteal fossa. We split arm across the chest. If this not succeed, we can move to the next maneuver, which is wood screw. Okay, wood screw means that I will introduce my right hand at 5 o'clock. Then I will of the baby until I reach the posterior aspect of the anterior shoulder, and will the left hand on 7 o'clock, and I will press on the anterior aspect of the posterior shoulder. Then I will screw like doing screwing. Next, I will go if this process succeed. Okay, not succeed, I will go to the reverse wood screw. Then I will move my last hand, which I introduce it, and my right hand follow the back, and I will put it in the posterior aspect of the posterior shoulder. Am I right? If this process is succeed, okay. If not succeed, I will rule the patient for all four position. Okay. If not succeed, I will repeat the all maneuver, but not the last one. If not succeed, invasive procedure, which is a symphysiotomy or symphysiotomy or clavectomy. Okay. Then I will deliver the baby. If not deliver, we can go to the theater. Okay. by do the management of the third stage of labor. وبعد ذاك lastly I will do debriefing and documentation. Am I clear? Any question you want to ask it? Thank you.
طيب, thank you very much يا وفاء. I think you did it in a good way. The things that I like so much is the continuous affirmation. You affirm from your audience اللي هم trainees that you are teaching them, the candidates you are teaching them, that everything is clear and you make sure that they are following you. You can just add to it, for example, can you repeat for me? Then the examiner will tell you, okay, no need. So I'll just make sure that they understand this point very well. Okay. The only thing that once you start teaching, you need to give a definition at the start. So you don't start immediately. You said that this is a obstetric emergency and we need to deliver the baby within how many minutes. Shoulder dystocia what is the shoulder dystocia? It's a bony impaction of the posterior arm under the symphysis pubis. So it's a bony impaction and not a soft tissue impaction. That's why whatever episiotomy or opening of the vagina, extra tears or extra incisions will not help. I need to remove, because the residents or the intern, they need to understand the concept of all the procedures or that you will perform, the maneuvers that you will perform. Be careful while giving informations and not to give them a wrong information. Macroperts alone is not responsible of 90% of resolving of the shoulder dystocia. Macroperts alone resolves around 40 to 45%. When combined with suprapubic pressure, it might lead to 90% resolve of shoulder dystocia. But macropert alone is not responsible of this. It's only 45 to 40 to 45% will be resolved by macropert, and 40%, around 40% or 35 to 40% if you add by the suprapubic pressure, so it will reach 90%. Patient has to be aware, and timing is very important, and you did not tell them that each maneuver, how long time it will take. So you have to tell them that.
I did, yeah, boss. I said 30 seconds.
You did?
Yeah.
30 seconds for each maneuver?
Yeah.
Okay. 30 seconds for each maneuver. And documentation and debriefing at the end. Okay, this is if it comes as teaching station. Okay, breech, delivery. You have a para 3 patient who is previous vaginal deliveries, 38 weeks of gestation. She came in active labor. She came to the emergency, pushing examined found to be 8 to 9 cm. Frank breech presentation, membranes ruptured, and she is pushing. Counseled, and she is willing for vaginal breech delivery, assisted vaginal breech delivery. And you have to say it, assisted breech delivery. Okay, assisted breech vaginal delivery. What are the steps? Who will take it? طيب, in the breach, and I think time will be difficult for us to take all. عندنا almost 5:30. So in the breech vaginal delivery, assisted breech vaginal delivery, there is a passive period and active period for you. So the passive is you just wait, and that is why careful is the mnemonics. Yeah, and this is the most difficult mnemonic in the also. I don't know why they. It is really difficult to be recalled. But anyway, you need to make sure you examine, you check that breech is down, the type of the breech, and you counsel the patient, you explain to the patient. Patient already explained, we explained to the patient, and she's accepting that she will go for assisted breech vaginal delivery. Okay, you will tell her that we might need to help you while delivering the rest of the body, especially the head of the baby. Okay, then this is address the situation. Then you tell the situation. Setting is it should be done in the labor room. The patient should be on the lithotomy position. The patient should be at the edge of the table with good positioning, good lighting, and I need a towel to be ready, and equipment for neonatal resuscitation. Pediatrician to be that this is a assisted breech vaginal delivery, and I might have after coming head of the breech, I might have baby with distress and who needs resuscitation, who might need resuscitation. Okay, so you need help with you, nurse, midwife beside you. Okay, and you need to alert the theater also if you need to interfere or you need to send the patient for any procedure. Patient becomes fully dilated. Patient becomes fully dilated. So what you will do, you just await for descent of the breech. Once the breech descends, you just support the perineum, you just support the breech until the buttocks is coming outside. You have to tell the patient that she should not push unless you make sure that there is a good descent, slow and normal descent with the contractions. She should not push. Why she should not push? Because I don't want her to push. The breech is soft and it can escape in a non-fully dilated cervix. And then I will be stuck with an entrapped head. So then you add the delivery of the legs after the expulsion of the breech. You keep them into the anteroposterior diameter, which is the largest diameter of the outlet. And then you sweep the legs, deliver the legs if needed. If not needed, it comes by itself, it's okay. At this step, once the legs and the breech deliver, you keep the sacrum anterior. And that is the most important thing. Always the back is anterior. Always back up. Rotate and keep the back up. And let the baby descend by itself while wrapping the baby with a towel. And why are we wrapping the baby with a towel? Why the baby should be covered?
To prevent vasospasm of the cord and hypothermia.
To prevent. What is the hypothermia will cause?
It will cause vasospasm of the cord. That's why we need to عشان نقلل البريشر بتاعه بنعمله gently to pull the cord gently and to wrap it with a towel.
احنا طبعا we should not touch the cord. قصة انه نجر الكورد ده ونزيح ونخليه loose is no longer adopted. You should not touch the cord. Once you touch the cord انت اللي بتعمل الفازوسبازم. You cover the baby to prevent hypothermia and to prevent the reflux aspiration, because the stimulus of the baby that makes the baby scream, the first scream, is the hypothermia. So once the baby being exposed to lower temperature after being expelled, the body expelled, will start to scream the first scream while inside the uterus or inside the vagina still. So aspiration is high with this. So you prevent the aspiration by wrapping the baby and keeping the baby warm. So wrap the baby with a towel, keep the baby warm to prevent the aspiration and reflux from the hypothermia. Okay? And hang the baby between the legs of the mother until the descent or the appearance of the scapula. Once the scapula appear, then you start rotating. Gently rotate the shoulder girdle to facilitate delivery of the left arm and then the right arm. What is we call this maneuver is the Lovzet's maneuver. So you rotate the baby while holding the baby clockwise and anti-clockwise to deliver the left and right shoulders, arms. Once the arms delivered, and if the forearm is still up there, you sweep the arm over the chest by applying pressure or traction in the cubital fossa. Okay, and always keep away from putting pressure on the long bones. Always pull from the joint. Don't pull from apply any pressure to the bones, to the long bones. Once delivered, then you will be handling the after coming head of the breech. Okay, and the question mainly will be there, delivery of the after coming head of the breech. How you will deliver the after coming head of the breech? The general steps of delivering the after coming head of the breech: assess and prepare. Check for the umbilical cord. This is not valid anymore. Cover the baby, wrap the baby in a warm towel to prevent coldness and stimulate respiration, because you want to delay the stimulus for the respiration. The fetal back should be kept in alignment with the cervical spine. Always back is anterior. Then you deliver the head of the baby. For the baby, actually there are not 2 maneuvers, there are 3 maneuvers to deliver the baby. The first one is Pracht, البراخت maneuver. والبراخت maneuver اللي هي lifting and pivoting. You grasp the baby by the hip and lift the baby towards, with 2 hands towards the mother abdomen, pivoting the head around the pubic bone. Or modified Maurice's Melvet maneuver. It is modified. Why? Because you place your index and middle fingers on the fetal maxilla to flex the hand and to flex the head, and use your other hand to hook 2 fingers over the body's neck or grasp the shoulders and apply gentle traction and lift the baby's head upward, pivoting the occiput back of the head under the symphysis pubis. You might need also assistant support by either suprapubic pressure to deliver the head of the baby, or you use a forceps, which is Piper forceps. How you will do the Piper forceps? Assistant should hold the baby and you apply from down the forceps the same way that you apply it for a vertex presentation or cephalic presentation. Okay? So if the head is impacted, or after coming head impaction, and you apply all the maneuvers and you couldn't, what you will do? Especially in a preterm labor or preterm babies. Sometimes the cervix will not be fully dilated and you need to do a Duher's incision. Duher's incision is bilateral incision in the cervix, avoiding the midline, where is the area of the uterine arteries, and go into 2 and 10. You make a 2 incisions at 2 and 10, and or 1 incision might be enough. Okay, and you hold this, the grip, you grip the cervix by a clamp or by a gripper, and you deliver the baby. Okay. Then as we completed that delivery of the baby completed, third stage of management of the third stage of labor, and documentation and debriefing. Baby has to be reviewed by the neonatologist for any intrapartum injuries. This is, what is this? This is Maurice-Melvet, modified Maurice-Melvet maneuver combined with suprapubic pressure, okay? Or this is Bracht maneuver, which is the baby will be hung, so it is flexed, and then you lift the full body up over the abdomen of the mother, and the baby's head, pivoting the baby. Pivoting دي زي كأنك بتخرطه below the symphysis pubis, or you will do a Piper forceps. This is a Piper forceps. So these are the 3 maneuvers to deliver the aftercoming head of the breech. Okay. Cord prolapse. Again, it's a top emergency. Management of the cord prolapse depends on 2 factors. Cervix, dilatation of the cervix, and the fetal heart. Okay? If the cervix is not fully dilated, the standard management is you aim at 2 things: relieve pressure from the cord and emergency cesarean section. How I will relieve the pressure from the cord? By positioning of the patient at Trendelenburg position, fill the bladder, keep hand inside, shift the patient to the cesarean for cut 1 cesarean. Again, cord prolapse is a top emergency. Baby has to be delivered within maximum 10 minutes from the diagnosis of the cord prolapse. Patient has to be shifted immediately to the theater if discovered to have cord prolapse. Theater should be alerted, anesthesia team, pediatrician, and senior obstetrician, nurses, everyone. Okay? Patient situation, patient, she has to understand that is very top emergency. She and her family should not panic, because we need to deliver the baby before the blood that goes to the baby will be compromised and the baby's heart will stop beating, okay? Or will be in a very bad situation. The patient has to understand the need of urgent delivery, either by cesarean or by instrumental delivery. Cord prolapse means delivery, whichever faster. If it is faster to do instrumental delivery, you go ahead. If it is faster to do a cesarean section, you go ahead. Cervix is fully dilated. You should not manipulate the cord at all. Just apply the instrument and pull the baby out. Okay? Then, so in the cord prolapse station, you just, it is very important the first briefing of the patient, preparation, all the preparation, and the conservative management of putting the patient on the Trendelenburg position, and or all in 4. Fill the catheter, put the Foley's catheter, and fill the bladder to elevate the head of the baby and prevent, at least reduce the pressure on the cord. And emergency delivery or accelerate the delivery of the placenta, third management of the third stage of labor, documentation and debriefing. I don't think this checklist is clear, but this is about cord prolapse. So you have to start by debriefing the patient and escalate. That is to say, escalate for the seniors and everyone. And at the end, the documentation and debriefing. PPH, minutes counts for PPH. Minutes counts. Simultaneous resuscitation, diagnosis, treatment, and monitoring. It's a teamwork, and team communications are vital. You need to know the bimanual compression, how it will be done, indication to go to the theater, and what to do there in the theater, indication how to call for blood transfusion, indication to go for laparotomy, or what to do there. Okay, في إيه هنا زيادة, and I'm very sorry for this mistake. Okay, so in a PPH still is the commonest cause of maternal mortality worldwide. Okay, despite all the interventions, you need to know the situations. You need to think 40s. 40s is atony, tissue, atony, trauma, tissue, and thrombin. Okay, in a sequence manner. So tone is more, then trauma, then tissue, and the least is thrombin. In postpartum hemorrhage, it is very important that you manage and you diagnose and you apply further monitoring of the patient at the same setting. So the initial management of PPH, you call for help. There is bleeding, you call for help. Help is from anesthetist, consultant obstetrician, and there is no place for pediatrician here. So anesthetist, obstetrician, helpers from the nursing side, okay? And someone to document. So you need at least 5 people around you. You start by ABCD, assess airway, breathing, circulation, and circulation immediately. Provide oxygen supplementation by oxygen, monitor the vital signs, start replacement IV fluids by 2 IV cannula, wide bore cannulas, and collect the blood. Obtain an intravenous line, put the catheter, assess need for blood transfusion, and send labs. This is the initial assessment. So until now, you did not give up anything apart from fluid, and you sent for the blood investigation. Okay, so call for help, assess ABC, provide supplementary oxygen, give oxygen, and give fluids. Monitor the vital sign and send the labs. The commonest cause of PPH is atony. How are you going to manage the atony? Drugs and maneuvers. Drugs, you need to review them: the oxytocin, methergin, carboprost, misoprostol, tranexamic acid. These are the main drugs that we use, and or centometrine, misergine or centometrine, apart from oxytocin, carbitocin, carboprost, misoprostol, and tranexamic acid. The changes now is that the tranexamic acid should be started earlier, as soon as possible. Okay, it improves the outcome. It proved to improve outcome by evidence-based. Oxytocin, many changes has been there in the guideline, but the standard is 10 immediately, and the active management of the third stage, and 30 international units in 1 liter fluid, and 500 we should be run during the first 10 minutes fast, and then the rest should be run over the next 1 hour, 250 ml per hour. Okay, and Mesergine, carpoprost. Second dose of the carpoprost, you need to think of transfer the patient to the OT for further exploration. طيب, what is new in the management, in the PPH management now, with the bimanual compression and manual continuous manual massaging? If you shift the patient to the theater, or before shifting the patient to the theater, you need to think about the new advances like JADA or JADA. JADA is a new apparatus. It acts mainly by, تعرفوا JADA? Anyone knows what is JADA?
جادة جاي من كلمة نجادة. لا أنا شفتها بالصورة زي النجادة، يعني نجيد اللي يطرس.
لا، اللي بتنجد نجد ده الستيتشنج.
أيوة صح.
جادة أيوة، ده ديك ال conservative stitching اللي هي دي البيلنش والموديفايد بيلنش، وفي lots of
أيوة
sutures.
قريبة للبيلانش.
الجادة، طيب الجادة it's not a stitching at all. الجادة عبارة عن أنبوب كاثيتر it sucks negative pressure. هي عكس البكري بالون. البكري بالون it keeps the uterus contracted by inflation وcompression على المكان البليدنج. ده البكري بالون. فالبكري بالون بيشتغل ب كونسبت مختلف. البكري بالون بيشتغل بالانفليشن، pressure by inflation. الجادة بتشتغل by pressure of by suction زيه زي الام في اي، زيه زي المانيوال فاكيوم اسبيريتر. كويس. الجادة it sucks so it creates a negative pressure، والنيجاتيف pressure ده بيخلي اليوترس to collapse، اللي هو الانتيريور وول اوف ذا يوترس والبوستيريور وول اوف ذا يوترس بيكونوا لاصقين في بعض مع النيجاتيف بريشر ده. فit prevents او it stops البليدنج و it causes a uterine contraction. واللي هي الفكره بتاعته جايه من وين؟ جايه من البايمانيوال كومبريشن. هو بيعمل نفس العمليه اللي بنعملها احنا بايمانيوال كومبريشن. We will compress the uterus in between your hands and wait until the uterus starts to contract. الجادة is the same concept. It uses the suction or the negative pressure. أنا حارسل لكم في الجروب presentation عن الجادة. So الconcept إنه هي it can be used for moderate PPH, mild to moderate PPH. It is very effective. الأكشن time بتاعها أقل in seconds. Within 5 seconds اليوترس will start to contract. عشان كده بتوقف البليدنج بسرعة جدا. The other thing, it doesn't need anesthesia. It can be applied لأنه ما فيها ما بتعمل أي pain. The patient doesn't need to be under anesthesia or in the theater. And it doesn't need to stay like the Bakri balloon 24 hours. It is only for 2 hours, 2 to 3 hours maximum, and you can remove it after that. طيب بكري بالون عنه بعد كده بنمشي للاكسبلوريشن او اللي هو exploration in the theater. Rule out any trauma and tackle it if it is there. Suture it, cervical exploration, and if not, if the bleeding stopped, that's fine. If not, then you go for laparotomy, and in the laparotomy you go for either conservative measures or non-conservative measures. Conservative measures اللي هي فيها بنقول عليها شنو؟ devascularization اللي هو systematic devascularization. Devascularization you start by uterine artery embolization, or then you go, or ligation, then you go into, this is uterine artery embolization by interventional radiologist, if available, and if the patient situation allows. If not, you go to uterine artery ligation. If not, you go further for bilateral uterine artery ligation, and then you go further for internal iliac ligation. Okay, and the conservative sutures, which are Bakri, B-Lynch, modified B-Lynch, okay, and or any reconstructive stitches that can be done, okay, and if not succeeded, then you go for hysterectomy or toweling, packing the uterus, or toweling after that. Management of the PPH, it needs debriefing of the team, debriefing of the patient and her family. Patient has to be vital signs continuously monitored. Patient to be shifted after that to high dependency unit, and consider blood transfusion or initiation of massive transfusion syndrome protocol, massive blood transfusion protocol, if indicated. If the blood loss is more than 2.5 liters, you need to go for massive blood transfusion protocol. It is very important, you need to check the Mayo's chart. كويس، early warning sign في حالة PPH, severe PPH، أو في حالة sepsis. Okay, so you have to say that I will follow the early warning sign chart أو Mayo's chart, maternal early warning sign، أو Q SOFA. كويس، Q SOFA اللي هي quick assessment of the general condition of the patient, okay, by the pulse and blood pressure only. Maternal cardiac arrest or maternal collapse. Again, second counts, quick diagnosis, call for help, activate code blue. You do a primary ABCD survey, and then you do a secondary ABCD survey. You have to put in your mind always, remember the 4H and the 4Ts. Functional 4H and 4Ts.
الهايبوثيرميا، hypovolemia.
Yes, yes.
hypoxia.
Yes, hypoxia. والتامبونات والثرومبات.
hypoxia. طيب الاتشز هما hypoxia, hypothermia, hypo and hyper kalemia, and hypovolemia.
hypovolemia.
طيب التي، الفورتيز،
التامبونات
ثرومبس،
والثرومبات.
تامبونات، تنشن نيموثوركس،
ثرومبوامبوليزم.
ثرومبس. T, and last T is toxins. Stands for toxins. Okay. Documentation is very important. Patient and family debriefing and team debriefing. طيب what is new في الماتernal cardiac arrest؟ زي ما فكرنا قبل، نفس الاستراتيجي اللي قلناها في الأول. Strategy is situation awareness, position and the place of care for the patient. Think of any transfer of the patient. Okay, اللي هو think of the ergonomics. طيب once you have a call for, you have cardiac or maternal collapse, you need to call for help. Call for help. Who? Anesthesia is the most important one. كويس. Anesthesia, senior obstetrician, midwives or nurses with you. Alert the blood bank. alert the theater, inform even the pharmacy, and you might need O negative blood if the cause is bleeding or hypovolemia. Type ABC, confirm that the patient is at cardiopulmonary collapse. How you will confirm? By the three things. You will do see and feel, see and hear. And you ask the patient, hello, 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 hello. She is not answering. Are you okay? Are you okay? She's not responding. You check the fetal pulse. Feel the fetal, feel the maternal heart by putting your hands, your fingers at the carotid artery and check for the pulsation. Look for the respiration, the movement of the chest, and feel the breathing or listen to the breathing. So look, feel, and hear the breathing, okay? Once it is confirmed, then you shout that code blue, initiating the code blue. Okay, code blue should be initiated if there is no pulse. The main concept of the management of maternal prolapse is two domains أساسيات. First, early start of CPR and early defibrillation. Early CPR and early defibrillation. CPR لازم يكون efficient CPR. طبعا انت you will start without knowing any history of the patient, and while doing you can collect some history from either a co-patient or from the nursing or from the people or from the EMS who brought the patient. Positioning, patient has to be flat and في hard service حتى لو تاخدها في الأرض. Okay, في hard service. The new thing is you do not put the patient on her left lateral, but you do what is called uterine displacement. You pull the uterus either by one hand or by two hands. You displace the uterus. You displace the uterus to relieve the pressure على الانفيريور فينا كيفا. مش كده؟ عشان تقلل البريشر على الانفيريور فينا كيفا. ليه؟ عشان تزيد البلد فلو تو ذا هارت. والانكريز البلد فلو تو ذا هارت. البلد او الفينس ريتين. You increase the venous return. هيعمل شنو الفينس ريتين؟ You increase the blood flow to the carotid arteries. The coronary arteries. You increase the flow of the blood into the coronary arteries. عشان كده بتزيد السبلاي للكاردياك muscles عشان to contract عشان to respond. Okay? فمع الكاردياك arrest that means the blood is not going out the heart muscles is ما عندها or diminished blood supply to the cardiac muscles. And that will lead to increase the venous return and increase the blood flow to the coronary arteries and thus more flow to the cardiac muscles. اوكي ده بس بيعملوا الديسبليسمنت. تمام. يبقى المانجمنت الالجوريزم of the active management of the cardiac arrest continue high quality CPR, defibrillation when it. Can you mute your mic please? Mute. Or any other emergency drug that is needed like epinephrine. Okay? Then you assemble maternal cardiac arrest team. طوال initially once you shout that there is code, you initiated the code blue, the cardiac assessment team or the cardiac resuscitation team, cardiac arrest team, they'll be notified. Okay? Then you consider the etiology of arrest. Perform maternal intervention. The most important thing is while you have a cardiac arrest, maternal cardiac arrest, forget about the baby. No fetal monitoring. Remove any fetal monitoring. Okay? The priority is maternal. Maternal life is a priority. Perform airway management, administer 100% oxygen, avoid excess ventilation, place IV cannula above the diaphragm, yani you put it high as much as possible. If receiving IV magnesium, stop and give calcium chloride or calcium gluconate. Obstetric interventions provide continuous lateral uterine displacement. That is the most important thing, and detach any fetal monitor that is there. Prepare for perimortem cesarean section. You don't need anything to do a perimortem cesarean section. Continue high quality CPR, defibrillation when you connect the defibrillator, and check the automated defibrillator. Now it will read and it will guide you if the baby, the maternal pulse needs shock or not shock, shockable or not shockable. So if it needs shock, you give the shocks. If not, you continue the CPR and you think about medication. If 5 minutes passed with full resuscitation and CPR without any regain of pulse, you perform a perimortem cesarean section. طيب عشان to perform a perimortem cesarean section, you need just a scalpel. ما محتاج لأي حاجة غير knife, and it will be a longitudinal classical incision, one incision from abdomen until the uterus. Uterus also longitudinal classical incision. Deliver the baby, clamp the placenta or clamp the cord, okay, or deliver the placenta and pack the uterus. You don't suture, you just keep the packing of the uterus and continue the CPR. If the pulse regain, the patient revive, you transfer the patient to the theater for suturing, intubation, and to continue monitoring after that. If the patient didn't revive after the perimortem cesarean section, keep it packed, or you can close it and you can declare death of the patient after further resuscitation. H's and the 40s: hypoxia, hypovolemia, hypo and hyperkalemia, hypothermia, thrombosis, coronary or pulmonary, tamponade, cardiac or tension pneumothorax, and toxins. Toxins, especially, you need to take some history of the patient. Okay. The take-home messages for maternal cardiac arrest is: resuscitation in pregnancy requires a specialized approach. Focus on resuscitating the mother. Fetal monitoring should not be used at all. Oxygen and airway management is crucial. Amiodarone should be avoided due to the risk of fetal thyroid and neurodevelopmental complication. Perimortem cesarean delivery should be considered if resuscitation does not occur, or revive after resuscitation of the mother, or revive of spontaneous circulation does not occur within 5 minutes, then you need to perform the perimortem cesarean section. I don't know why this is here. Any question?
طيب يا بص في الفيتال مونيتورنج كنت في الماتيرنال كاردياك اريست بنعمله. طيب هنعمل البوست مارتم زي تكشن على أي أساس إذا كان أصلا هو ما عملت له مونيتورنج يعني، كان ضايع يعني.
ايوه انا هعمل البريمورتم ليه؟ why I'm doing this
ايوه
cesarean section perimortem cesarean section. What is the
priority
benefit of
to
the
save the
perimortem
mother.
To
cesarean?
save the
Save
mother.
the mother.
It's done to save the mother, to increase the venous return that is coming to the mother.
Yes.
So
Triple compression,
yes, so
uterine compression.
yes.
ايوه كده وقعت.
السيزاريان ايوه السؤال ده كويس. اللي هو الفهم بتاع الناس كله انه احنا بنعمل السيزاريان سيكشن البريمورتم سيزاريان عشان to save the baby. لا
نعم.
احنا we don't want to save the baby، احنا we want to save the mother. البريمورتم سيزاريان سيكشن alone لما تعمل سيزاريان سيكشن and you clamp the placenta بترجح 40% circulation من البلد circulation to the mother اللي هي ماشيه لليوترس. 40% من البلد فلو to the uterus بترجعه تاني للماتيرنال circulation. عشان كده البريمورتم سيزاريان سيكشن for the sake of the mother and not for the sake of the baby.
تمام وقعت كده بس.
كده وقعت لك؟
وقعت هيا بس.
Okay. Any question? What is not mentioned here in the من الأوبستريك emergencies هي الإكلامسيا. بس أفتكر الإكلامسيا و maybe when we do the gynae emergencies ممكن ناخد معاها كمان الإكلامسيا or we will allocate الإكلامسيا دي ل one separate day إن شاء الله. تمام؟
تمام
تمام،
بس دي
يديك العافية يا دكتوري، جزاك الله خير.
يا بص لو الستيشن دي هتجينا مثلا في الأوسكي إن شاء الله هتبقى الماتيرنال كولابس، ممكن تجي في توصيغة يعني فايفا.
ممكن تجي فايفا. دايما السكيلز دي بتكون يا فايفا يا ديمونستريشن عادي. السايكل بتاعت السي بي ار مع السي بي ار مع الاكسجين كم وكم؟
50
you need to perform
to 3
32 32
30 ايوه 30 سي بي ار و2 بريس اللي هو انت عاوز الريت اوف 100 بير مينيت. اوكي فعايز السي بي ار بتعمله 30 سي بي ار و 2 بريس you give a 2 بريس by mask بالشيلد ماسك. الستيشن الاوسكيز ما ممكن يكون اوسكي وما يكون فيه obstetric emergency. For one of these emergencies that we discuss now 100% is there in the exam. 100% is there. يبقى you have to be ready for them. احنا بقول لهم دي واحدة من الحاجات الأساسية اللي بتخليك تضمن انك انت بتجيب درجة كويسة في mute because you are approaching the end. طيب يا جماعة باقي النقاش ممكن تسألوا أي أسئلة في الجروب. If you are interested we can you can put there every time I'm saying this and you can approach us as instructors or teachers. أي واحد مننا ممكن يجاوب لكم. Thank you very much. شكرا يا خالد. Thank you and this is the end of our session today.
تسلم.